And without further ado, we've changed the order of the speakers. So we've got two people talking about substance misuse later, but we're going to start with Nick Maguire from the University of Southampton. So in the last meeting, we had a very lively discussion about reflective practice, and this is following up on that. Nick is going to talk about sharing an evidence paper on reflective practice. So I'll hand over to you, Nick.
Thank you very much, and thanks to Sophie for coping with my late responses early this morning, having confabulated that I'd actually let her know that I'd be here. So much appreciated. Okay, I'm going to share a slide deck if that's okay. So can you see the slide deck?
Yep.
So hopefully reflective practice, evidence and mechanisms. I can see you, John. You're in my feature. Can you see them, John? Brilliant, thank you. So just to credit, Sana James did most of the work on this. She is a very talented assistant psychologist, and she works with us on some of the social enterprise stuff that we do. So what we did is a very rapid review, I guess, a sort of systemic approach and a rapid review of the existing literature around reflective practice for Pathway, so that we could at least start to get a picture of what the evidence might be, and particularly and what the limited evidence has picked up some quite nice, interesting mechanisms of the effectiveness of reflective practice. Now we can think of it from a couple of points of view. We can think of it from a kind of a theoretical point of view. And why reflective practice might be useful in terms of a pedagogical process, how it is that teaching takes place and learning takes place within reflective practice. And then also we can go to the evidence base, limited as it is. But I'll talk a little bit about the limitations of the review when we get there. So firstly, it's useful to think about Cole's learning cycle when we think about reflective practice. So whenever you're learning a skill, it's not just about knowledge, it's about practice, right? This is a really nice framework for thinking about it. So generating concrete experience by going and doing what we're doing, engaging with people, generating experience of what happens when you engage with people in particular ways, and reflecting on that. And the reflective practice, of course, is an ongoing way of reflecting on our concrete experience, trying to make sense of it. And it has to be an ongoing process. You can't just do it once. If you're going to enable skills and the ability to bring a knowledge base to your skill set and change your behaviors, then this kind of ongoing reflective process is important. From that, we generate new understandings of what we've observed, what we've experienced, what we've seen, whether that's somebody else's behaviors and the impact that has on us, or whether it's how we enable somebody to think about changing behavior. And then we go out and try it again. So try it with our new sort of understandings of what's going on, and so the cycle goes on. So teaching, for example, tends to be, one-off teaching tends to be effective in perhaps changing attitudes, a little bit of knowledge. Rarely do you change your behaviors when you're engaged in a sort of a one-off or a two-day training event, for instance. If you want to change behaviors and you want to acquire new skills, you have to get into a kind of a learning cycle, and this is what Cole was describing. And reflective practice is one such cycle. There are other ways of thinking about it, but this is a useful one. So moving to literature then, what Sana did is she took a systematic approach and used two quality assessments relevant to the papers that she found. She found a number of qualitative papers and then a mixed methods paper. So the multiple methods used, assessment tools used the mixed methods, and she used the critical appraisals skills program to assess the qualitative data. Inclusion criteria, they had to be directly measuring reflective practice or assessing reflective practice, and it had to be within our population. So people who are homeless and also people with adverse childhood experiences, where homelessness was an issue that had been cited within the population, so slightly broader. It had to be in English. We didn't have time to get translations, so we stuck to English papers. we excluded any papers not specifically about reflective practice, which made it a very tight review. We could go looser, which I'll talk about a little bit later. And any that couldn't be applied to homelessness services. So we really wanted to think about homelessness. Again, we could have gone broader, but that would have been a slightly different review. In terms of the Prisma diagram, you can see that she didn't find many. She, even at the kind of the top level, she only found about sort of 40 papers, not the thousands we often get. So this is an under-researched area within the peer review literature, at least. And then she got down through a process of through this process to about four studies. So it's only including 4 studies, so it's a very limited review. But nevertheless, it gives us some ideas to work on and some ideas to think about how to take the review forward. So in terms of the results, so she included 4 studies, 3 were qualitative, 1 was multiple methods, 2 were in the UK, 1 in the US and 1 in Ireland. And the range of the participants in each study, 6 to 30. So the qualitative studies obviously had fewer people, and the mixed methods one still only around about 30. So we're not getting large numbers within this. Overall, 2 themes emerged. One where people were describing and people had found reflective practice to be effective, and others where they had described reflective practice not to be effective. And that gets kind of fairly quickly nuanced. So in terms of when they found it effective, there was some good or some evidence that it prevented burnout, improved problem solving, and it increased staff confidence. Now, this is something, so we've got some unpublished data which kind of indicates the same thing. So we find that it does affect burnout, and we reduce particular components of burnout in the unpublished stuff that we've got, which we do need to write up. And we find that there's also a kind of a mediation, which is kind of interesting, where it's the confidence, when you increase staff confidence, particularly their ability to think of themselves as effective, that seems to mediate the relationship between the way people think about the population, particularly negative beliefs, and some of the burnout stuff, particularly depersonalization, where people sort of start mailing it in and just and stop kind of, they get burnt out, they stop really engaging with people, they lose hope, and they're just turning up for work. And when people start to get like that, it's very hard. It's very hard for them, and often people will then leave the business. So that was important. So we can start to think about mechanisms, and from our research, the increased confidence is really important. When you enable staff to be increased confident, and so specifically when you enable them to understand how they're effective. So there's something about helping people to understand small increments of change, a big acceptance process about when you can't, when you don't engage in change, and when people don't change as a result of your interventions. And the really important thing, and this is something that we've been talking about a long time, but we haven't done it yet, is there seems to be evidence of behaviour change. In other words, staff are changing their behaviours, and they are enabling behaviour change, increased behaviour change with the people with whom they're working. And so that's a kind of an important finding that really does need to be replicated and explored. In terms of the people that thought that reflective practice isn't effective, it was definitely when attendance was sporadic. So there's something about a moderator there of effectiveness around attending, and when people weren't attending regularly, there seemed to be certainly kind of lower results, and they didn't seem to benefit from it. And why didn't they believe it well, there's a number of possible reasons why they don't believe it to be necessary. This is what they're reporting. What anecdotally we find is that there are a number of facilitator factors. Perhaps as facilitators, we're not creating a safe space. We're not enabling people to talk honestly about their experiences, or perhaps we don't do enough to kind of help people structure it. We've got all sorts of methods of reflective practice, ranging between sort of very psychoanalytic or psychodynamic methods, which might just be not saying anything at all, through to sort of semi-structured and structured forms of reflective practice, which we more favour within the kind of cognitive behavioural paradigm. Anxiety, I think, is it's a big thing. I think there are a number of beliefs, anecdotally, which moderate maybe people's willingness to come. And one of them is, I'm going to get found out. You know, they can't, I'm going to be vulnerable. They're going to judge me. They're going to see that I'm not doing my job properly. And so I can't come and discuss it. Now, one of the ways that sometimes gets expressed is, oh, no, there's too much chaos within the hostel or within the service, and I need to attend to it. And so people don't prioritize reflective practice. And of course, there is always chaos to attend to, or there's always a need. And so you can use that. If you don't want to turn up to reflective practice, you can always use that. And we certainly see that. And you know, the report is too much to do. I can't possibly spare the time. This is one of the things that came out in the literature, was people saying that it's just too much to do. We would move that to thinking about prioritizing and how then the organization thinks about reflective practice, and then how it prioritizes it to enable people to give themselves permission to attend, and ensuring that there are enough people on shift in order to be able to cope. So these are things that people are describing. You know, it's not necessary, but anecdotally underneath, we think there might be a number of factors underpinning that. Limitations of this particular review. There is definitely a selection bias. Of course, what they were doing is most of the people in the studies were people who were attending. So very few people who weren't attending, although there was some data, obviously, particularly around people who are finding it not, the reports from people finding it not effective. Very small, only 4 at the moment, and then very limited power in terms of the study. So statistically, we've got low power. We didn't go to the grey literature, and there's all sorts of interesting reports and stuff in the grey literature. For this, we just wanted to stick to the peer review literature, just as a kind of a small rapid review. A future review, we could do something a bit more realist review, perhaps including the grey literature, and to think about a little bit more about mechanisms, and to look at what people are reporting as to as to why things aren't effective. So the conclusion from this short review of a limited number of papers is it is effective, but there are moderating factors, certainly. Some of those are around the way in which reflective practice is configured, and some of those are around the way people experience or people's beliefs about reflective practice that a good facilitator and engaging with the management structures of any organisation would need to take into account. And there I'm going to stop. Any questions?
Well, thanks very much for that, Nick. I found that really succinct and useful and interesting pointers. One thing that strikes me, and maybe it's because of the CBT approach, there seems to be absolutely no conceptualization of emotion, and also of irrationality. And I wonder whether in the future those could be seen as certain moderating mechanisms, you know, individual defenses, individual issues. A lovely survey of facilitation factors, prioritization, and I think you quickly mentioned something about the preparation work. You know, is the organization culture prepared to address what are threatening possibilities? But that was great. Thank you. Thanks very much.
Yeah, cheers, John. Yeah, I think emotions were in there, in that those were some of the things that that maybe the anxiety bit, that people were worried about it. And because of course, you know, some of the beliefs might be, you're going to strip me, you're going to make me cry, you're going to make me annoyed, you know, I'm going to have to show those things. But that's kind of fairly limited in the qualitative stuff. So, you know, some of the themes were coming through around that. But you're right, they absolutely. This is just a little starting point. That's one of the ways we need to jump off, is to look at, well, okay, what's going on for people? Is it inherent within people's experience, or is it people who are just not going because that's what they fear is going to happen? And you're absolutely right. Yeah. Thanks, John. I think
Thank you, Nick.
next, and then Alex.
Yeah, gosh, who's next? Was it Robert? I can see Robert first on my list.
Hi. Hopefully I've unmuted.
Yeah.
Rob Whittaker from Bevan in Bradford here. Thanks for that, Nick. It's really, really thought-provoking. So I was just interested in, you said something about behaviour change, both in terms of service users and staff, and I wondered if there's anything else you could tell us about that?
So anecdotally, one of the functions of reflective practice is to allow people to, and I'm going to use some sort of slightly DBT language, is to notice the urge to behave in a particular way. So somebody does something which is inexplicable, you get annoyed or you get worried, and you react in a particular way, which could be unhelpful for that person. You might make a judgment, you might say something, you might avoid. Now, one of the things that reflective practice can do is or we would deal with is what's happening, what are you doing which is less helpful for that person, and why are you doing it entirely. And it comes back to John's point, it has to be normalized. And one of the big change processes, group theory processes of change is normalization. So, oh my God, you do that as well. You get get that. God, I wish I hadn't done it, but I had. Yeah, I did that kind of thing. So normalization is really important. Now, if you can spot an urge, so before you do it, before you either avoid or before you say, no, I'm not talking to you right now, bit of a hand up kind of thing, can you notice that urge to do that? And can you just stop and listen? And just, even if they're shouting at you, stop and listen and try and hear what it is they're saying. And that's a real skill, the skill of shutting up, the skill of not giving advice too soon, all these kind of things. So when we spot those kind of behavior changes, funnily enough, we spot the dynamic, the kind of the interactive process is afoot, and we start to see people, when you sit and listen to somebody, they gradually calm down rather than saying stop shouting at me, when we will wind somebody up. So we can start to, if you can start to understand your own emotions and then the urge to behave in a particular way to cope with those emotions, that tends to have an impact on the relationship and the dynamic in that moment and going forward, which is more likely to result in more engagement behaviours from the people we're serving. Is that reasonable?
Yeah, no, I think it's really interesting, and it really mirrors our experiences of running quite a lot of reflective practice groups with different groups of staff here. I was interested in how you sort of measured it. So it was self-report really from the group members. They were saying that their behaviour changed rather than anything more.
Absolutely, I can put all 4 studies up actually if you want. I can send them through, or I might be able to put a file in the chat, or we've also got the review, and you can see the 4 studies and you can go to them for the primary references if you want. But this is mainly qualitative, I think. What I'm doing is a slight interpretation according to my own experience, and the kind of things. A little bit of group theory. There's a guy called Irving Yalom who did one of the seminal texts on change processes in groups, and so normalization is one of those things.
Yeah, really helpful. Thanks, Nick.
Yeah, thank you. I'm sorry to move people along. There's a few hands up, and I'm going to pronounce your name wrong again. Eleanor, tell me, and I'll remember for next time.
It's fine. Hi, I'm Lee. I'm a clinical psychologist in Edinburgh. Thanks so much. That's really interesting to sort of see, I guess, some of the stuff that I'd found in my systematic review of PI interventions, which included reflective practice, actually really mirrored in what you found as well. Especially, I think it was one of the mechanisms that I had theorized might exist without saying that it was causal, etc., in terms of increased confidence being one of the really big mediators.
Yes.
And I think it's really nice to hear that sort of being backed up, that actually it's something about reflective practice that is protected. It feels good. It's nice to be able to work to sort of, feel less burnt out, but also actually there's something very formative in that having more confidence and working with really complex people makes you more likely to stay in your job and to enjoy your job more and feel more satisfied.
Absolutely right.
Which I think, if we've all felt out of our depth at some point in our work, and I've found that difficult. So it's nice to have that. Is it being published? Or
no, we wrote it for Alex basically, because we promised to, and actually I think it could be a nice little thing, and it'd be lovely to get Sana to do it because it'll build her CV. So I'll get her to write it up, for something small. I think there's a bit more work to be done on the limitations. There's a little rapid review. I think it serves its purpose, but it points towards the need for something a bit bigger and a bit wider. Interestingly, apologies, I think maybe one of your papers got excluded because it was around pi stuff. So we excluded
okay.
the pi stuff
That's
and just
fine.
included the reflective practice stuff.
Yeah.
So apologies.
No, that's okay. I think it's interesting that we all have a shared understanding that overall reflective practice equals good and we should do it, but we have very little evidence to back it up, which makes it difficult to then say, Mr. Commissioner, please could you give us some money for reflective practice?
Right.
So it's nice to build that evidence base. But yeah,
Yeah,
looking forward to
absolutely.
reading it.
One of the there's loads of ways of expressing why it's a good thing, and those moderators. So one ACT talks about behaving in the service of values, and I think one of the things that is very challenging is you're behaving in the service of values and nothing changes, and so we start to interpret that as us not having value and us being ineffective. And if we can get underneath that, and so seeing the tiny little increments of change that. Yeah, I'm behaving in service of my values, and there is change, demonstrable change, tiny as it might be. So that's, I think, one of the functions we're really working on too. Thank you. Thanks, Reed.
And next hand up was Emma Marsh.
Hi, I'm Emma. I'm the clinical team manager and psychotherapist for a new mental health service in Leeds.
Emma.
We're not live yet. I really enjoyed that, Nick. I'm really big on reflective practice. I think it's really, really valuable. One thing that really got me thinking about, particularly living in the hybrid world that we are living in now, obviously pre-pandemic, all services that I worked in, reflective practice was face-to-face. You really got the value of it. You really felt safe, and you had really good facilitators, and it was really able to manage. What I've noticed post-pandemic, any reflective practice groups I've attended have been online.
Yeah.
I felt that they're not as effective. I mean, again, as a psychotherapist, I do work privately online and face to face, and you don't pick up on the nuances that people have, and I feel like there's a lot missing, and people are kind of doing the re-emails while they're on reflective practice groups. And I'm just wondering whether there's any research or anything, any thoughts that you have on face-to-face reflective practice groups versus online, because given what you were saying about limitations and time constraints and people attending sporadically, that's been something that I've experienced. However, now I'm assuming that the feedback's going to be, can't we just do it online if we're proposing a face-to-face group? So I'm just interested in your thoughts on face-to-face versus online.
Brilliant. So I've thought a bit about this quite a lot. I think there's a bit of evolutionary theory which is really quite useful here, and one of the key things that we're missing online. So obviously when we're talking to people and we've got them face to face, empathy, there's some lovely evidence around empathy being partially around micromuscular movements in our own faces. So we detect emotions in others by mirroring those emotions in us, and really interestingly, in terms of the facial set, so we're actually mirroring the muscular movements. I can't see any micromuscular movements online in a tiny little square, and so therefore I'm wondering, I think empathy is harder to generate, because you're relying on the content of what people are saying, the more gross movements. You can't see the tiny movements around the eyes anymore. There's some lovely work done with Botox, and they found that people who maybe had Botox and who therefore had less movement around the eyes struggled a bit more with empathy, because they weren't getting that, my face is doing this, so therefore this must be what's going on type thing. And it's an evolved approach. Language doesn't come along until about 350,000 years ago. So most of our 7 million years of evolution is no language at all. So you need to understand and develop a highly attuned mechanism to understand what's going on in somebody else's mind and feelings. And we don't have that. So I think, and it's just I think, I don't know, there might be some evidence around it, is that one of the reasons it seems to be less effective is because we're struggling to empathize, to the fullest extent, and therefore it's harder for people to be honest and to be vulnerable, because we don't have those little interventions. That's what I think. On the practical level, easier to do online. You can engage more people, less travel, etc. And so arguably you might get more people in the room, but I'm wondering whether what happens in the room when you get them there is less effective, and maybe that's matching your experience.
That's brilliant, thank you.
Really interesting, Nick. Thank you. It's nice to have some concrete argument against hybrid or online. Although it's nice to be with everybody today, it's nice to hear that about empathy. There's a comment in the chat from Suzanne saying, Suzanne and Lester, are you there? Maybe not, but saying that it's important.
Yes, I'm here.
You are. I just wondered if you wanted
Sorry.
to say your comment out loud.
Yeah, it was just about quite often within a PI approach, reflective practice is paired with training on psychological skills using a psychological framework, and how important, if confidence is the mediating factor to reflective practice being effective, then one of the important things in the training is that it's not focused on passing on information or coming from an expert position, but more kind of working with the skills that the staff group already have. And my experience of training staff in the homelessness sector is that you've got a huge amount of talent and resources right there in front of you, and there's some work to do kind of changing people's expectations of the training, because when people come to training, they expect you to tell them give them some expertise, but then once you've gone past that, you can really gain a lot from staff working together and learning from each other and building connections over the things that they're doing really well. So that was my thought, is how important it would be for the training element of PI to be reinforcing the skills that the staff have already got, rather than trying to expertly impose new skills.
Brilliant.
Yeah, absolutely. I mean, I think that's one of the really good things about reflective practice, isn't it? That it should be a space for that to happen, and it's probably important to keep it for that rather than try to impose training in the same space. But other people would know more than me. Alex, you're the last hand remaining, and we've got a couple of minutes for a quick question.
Thanks, Jenny, and thanks, Nick. Really interesting. Yeah, thanks for the paper before, and I hope colleagues see why I asked Nick to have a look at this, because it's, for us, it's really important, we think, and we need to do more to build the evidence base, but we need to keep going with the arguments just to say it should become what's just done in our sector, we think. But as a couple of kind of practical questions, does it say anything about team dynamics and group dynamics, either as improving, or whatever that means in some senses, how teams are working? And I remember talking to colleagues, one of the London teams, about helping, particularly in the context of complex behaviours and actually framing responses to an individual client, and how helpful those discussions were. But I guess that was actually also building their confidence. But yeah, so is there anything in the paper about
Short answer, no, not in any detail. I think, you know, teams and team dynamics have been mentioned, but no kind of attempt to try and understand what the change mechanism may be. And I think, I don't think there's any concrete evidence on which direction team dynamics are moving. And we know that Brené Brown's got a lovely narrative about this. She does some really good shorts on things like empathy and shame and vulnerability and stuff like that. And we know that good evidence around when somebody makes themselves vulnerable, they talk a bit about something that, they haven't quite got right. We evolve empathy, we develop empathy for them, and we know them slightly better. And team dynamics can be difficult team dynamics can be interfered with. Because you know a bit more about the person, you can come to like them a little bit more, and you make fewer assumptions about why they're doing what they're doing. So there's something about vulnerability and empathy that goes along with that. And so again, this is what I think are the kind of the mechanisms around teams. So there's something about coming to know members of our team. There's something about pricking prejudices and particularly maybe negative beliefs we have about what people are doing and why they're doing. Again, sort of framed in cognitive behavioural terms. You can frame it any way you like. But that's something that I think we could be doing a lot more of. There's sort of hints of it in these papers, and it's one of these massive things to kind of explore.
And then my second question, Nick, was about kind of dose response, I suppose. Kind of how much.
Be a quick question, Alex.
How much is enough, and is it once a month or once a week, or kind of anything on?
Great. I think it's once every 2 weeks. Once a month is you can get effectiveness over once a month, but you lose the thread. It's hard to kind of pick up the thread from the previous meeting, so you lose continuity. So it's not a singular dimension, effectiveness. There are multiple dimensions of effectiveness, and one of the so once a month enables a group kind of feel. I think the group dynamics theorists amongst us might say that it kind of needs to be a bit more often if you're going to be properly forming. But once a month is okay. You get content. We used to do it, and we used to get productive content. But there's something about losing the threads and being able to pick up the threads from the previous things and checking things out and seeing how things went. So you remember that learning cycle. So how do I check out when you've gone away, done something, found something new, and then we complete the cycle by exploring that new thing. That doesn't tend to happen, I don't think, in once a month. I think you need a bit more often to do that. Again, these are my thoughts. I don't think there's any concrete evidence around it.
Thank you, Nick. I'm going to have to sadly draw a halt to this discussion, but Sophie has offered if you send Sophie the papers, then she's offered to distribute it to the group. And there's a few more comments in the chat which are interesting. But I am going to hand over to Iveta because we've got other things to talk about, and this sounds very interesting.
Thanks for inviting me. Much appreciated.
Thanks. Thank you, Nick. Good to see you. I know you need to get off, but stay if you can for a bit.
Thank you.
The next speaker is Iveta Tsenkova. I hope I'm saying that right, from King's College, just down the road from me, who is going to talk to us about a realist evaluation of a psychosocial substance misuse intervention for young adults experiencing housing insecurity, which sounds fascinating. So I will hand over to you, Iveta.
Thank you. And you managed to get my name on like almost the first try, so well done. Doesn't happen very often. I'm just going to try and share my screen, and I don't do this very often, so can you guys see? Oh, awesome. Cool. And if I go for slides, perfect. So I'm going to try and follow what Nick did very effectively and give you like a short presentation of my study. So I'm going to preface this by saying that this is early stage protocol for a realist evaluation, and I'm going to explain what a realist evaluation is. But I am completing this as part of my PhD, and what I'm trying to achieve very hopefully shortly will be to get an NHS approval and then publishing this protocol. So what is the realist evaluation to begin with is that I'm doing an evaluation assuming that a service does not work the same way for all individuals, and based on an individual circumstances, this service or an intervention will affect and trigger different mechanisms that actually we see as outcomes later on. And I'm focusing on young people between 18 and 25 who are experiencing homelessness. And I'm going to begin very quickly with not giving you too much information because I imagine you already know quite a lot. But according to Centrepoint's latest report, there is currently for the last year, there have been 122,000 young people in the UK who were experiencing homelessness, and that is young people just between 16 and 25. And it is a slight increase from the year before, but for the last 5 years, there has been continuous increase. And that is since 2017 to 2018 reports, there have been continuous increase year to year. I do want to very briefly touch upon youth homelessness and just the variety of the definitions that there are. There's the European Federation of National Organizations definition, which is for young people 13 to 25 who are experiencing housing insecurity, rooflessness, houselessness, inadequate housing. There is also examples that I have put down on my slide that is from the National Drug Treatment Monitor System definitions, which is within the UK. And we have different categories within within the definition that they're using there. And some examples are sofa surfing, supported accommodations, living with friends permanently. We have people living on the streets, squatting, etc. What I do want to touch upon is how young people come into homelessness. And according to there's a figure, if you see down on the left bottom, there is the biggest factor of family no longer willing to or able to accommodate. And according to latest statistics, actually, domestic abuse and the factor family no longer willing to accommodate have actually been increased as factors for the people who've participated in the studies. that those are the biggest factor increase for young people to present to local authorities or seek support for homelessness. And my focus is, oh, my slide is not moving. Okay, we did it. My focus is on substance use. So I did want to show here, this is a figure from Young and Homeless from 2021 from the Homeless Link, and they did a breakdown of male and female factors for young people presenting as a homeless, and as we see, these are the biggest factor. But my focus is on substance use, and here I am talking about alcohol misuse, as well as illegal and illegal substances. And I wanted to point out that this is a figure, again, from 2021, which shows what are the support needs for young people who are presenting to local authorities as well as NGOs, and what kind of needs they have. And I did want to highlight that there is at least 39% for young people who themselves recognize and have reported that they have that need for support for substance misuse, 70% for young people who are using legal highs, as well 50% for alcohol misuse. And research has actually linked substance use and housing insecurity or homelessness. I'm going to use housing insecurity and homelessness quite interchangeably, just so that you're aware. But research has shown links between homelessness and substance use, and that has been ongoing in the last 30 years. There has been continuous research showing that there is a high risk behaviors such as substance use, high risk sexual behavior, who are very linked with homelessness. Recent studies had also shown that there is a 48% of homeless youth meet the DSM-5 criteria for alcohol abuse or dependence, and 39% for substance misuse. So kind of what I'm trying to address, and there is quite a lot of information here on the slide, I apologize for that. But what I'm trying to address is the fact that young people are presenting to substance use services, and their needs may not be met. So there is some mixed evidence on how good the outcomes are, what exactly components of different interventions and different services are affecting or are being helpful to the young individual when they present. So as you're probably familiar, young people between 18 and 25, when they present to a substance use service, they are considered as adults, and therefore they're receiving the same intervention together with or other individuals presenting, and that is individuals 18 plus. The research, for example, this really highlights from Borto and Haring et al. From 2012 really highlights that there is a need to see what are the mechanisms of work of the services for this particular population, so that the interventions and services in general could be improved. So what I'm focusing on in my research is seeing how and why, to what extent, for whom, in what circumstances, psychosocial substance use interventions work. So the focus on psychosocial substance use interventions is focus on interventions and services that are encompassing psychological and social components. So we're looking at motivational interviewing, contingency management, etc. So these type of services. And the idea is that through a realist evaluation, I want to break down different components and mechanisms that trigger for a young person to reduce their substance use, or for their housing insecurity to be reduced. So this is a brief information on what the different components of a realist evaluations are. So I already mentioned context, which is the features of the situation, individual characteristics, etc. Then we have the mechanisms, which is a big focus of the Realist evaluation. So we're looking at the ways in which an intervention actually creates change, and the evaluation is completed through looking at a context mechanism outcome framework. So shortly I will present to you what context mechanism outcome framework I have created, but I did want to highlight that for the Realist evaluation, there's different stages or phases of it, and the thing that I'm presenting today is actually the result of stage 1 of my evaluation. So what I have done already is I've done a systematic literature review of the theoretical models that have been done in the last years on substance use and youth homelessness. I've also completed literature review on service evaluations of substance use services for specifically young homeless individuals. And a big component is stakeholder input. So I've had many conversations with individuals working at different levels in substance use services. So there is a lot of anecdotal evidence which has supported what are the main components and contexts that need to be evaluated. And that has been placed on the background of the theoretical models and the service evaluations that I have discovered. So the next stage is the next stage of the Realist evaluation, which will be completed, is work with different substance use services and information that they're already collecting for the national drug treatment monitor systems, and qualitative interviews with staff and service users. Staff and service users. And the idea is that all of this information through mixed methods of review of the data will help to actually redefine and narrow down all of these context mechanisms and outcomes and present theories, final theories, which will help with work on policy as well as development of services. And this is where I'm at. So the context, mechanisms and outcomes that I have created based on the stage 1, as I mentioned. So the focus is 18 to 25-year-old young adults experiencing housing insecurity. And here housing insecurity can mean anything that falls under any of the definitions that we saw earlier based on FINSA and the National Drug Treatment Monitoring System. But there is, again, a bit of a breakdown based on some different circumstances of the young individual. So I'm looking at 3 main categories of young individuals who have or don't have supportive social relationships. So from anecdotal evidence, I have heard a lot about the existing connections that young people have when they present, how that may affect the type of support that they're willing to engage with and their outcomes. So this is the main component that will be investigated. And then I'm also looking at these 2 are the same context of young individuals, again, with the same characteristic of homelessness and the same age groups who have high levels of disaffiliation. And disaffiliation is a term that's used a lot in literature and research. And the idea of disaffiliation is individuals who are not engaging with services due to different reasons. And I am categorizing this as individuals who have approached before a service but have not engaged with it and because of different factors such as stigma, for example. Individuals who have had experience of living on the streets, as that has been linked with their unwillingness to engage. So these are the 2 contexts that I will broadly be looking at. But the main mechanisms and the main focus would be investigating how the components, 3 components highlighting here, communication and relationship building, trusting relationships with mentors, key workers, staff in general, and education and responsible use trigger or make the young individual create a social relationship with a person who is non-using and supportive in the young person's journey to lowering their substance use. And I wanted to focus on that, as a lot of the, again, anecdotal evidence of staff has been staff and stakeholders has been around the type of environment that the young person lives in and the type of people that they're living with, the type of behaviors that they exhibit in the same living environment, the type of behaviors that are supported in the social network and considered as normal or are usual behaviors. And I want to see if these components of communication, trusting relationships, and the education responsible use may trigger individuals, young individuals, to kind of look for a different social network, to look for further support, for them to start rethinking some of their attitudes and beliefs for around substance use. And that is the main focus. So the outcomes, of course, will be taken from the data that's already collected. And again, that will be a lower levels of substance use and housing insecurity. And this will be done in, there we go, with participants in 5 sites. So that will be 5 different substance use services. And I will be collecting interview data from staff and service users. And these are the characteristics that I'm looking for. Yeah, so I haven't given much information around the data analysis or what I'll be collecting from the National Drug Treatment Monitoring System data that's collected, because, as I mentioned, we still haven't received ethical approval. Once that is done, I'm hoping that we can publish this protocol and the findings from stage 1, so that that can trigger some more research to be done around the stages on this population. Yeah, so the overall impact, as I mentioned, obviously addressing some research gaps that I mentioned earlier, to show that there is a link between housing needs and substance use and addressing those together. So I'm hoping that through the examination of mechanisms and outcomes, it will be obvious that the data will show some links in addressing those needs together and not separating services between housing, between substance use, and the need for those to be more interlinked. I'm hoping that whatever data we find and whatever theories come out will be useful for the services to improve some of their practices, or to continue doing what they're doing if it's working. And hopefully there will be some policy implications depending on what those findings are. And that is all. Thank you very much. And yeah, do you have any questions?
Thank you, Iveta. That sounds phenomenally interesting and a lot of work. This is your PhD, is it?
Yes, this is already 1 year's worth of work that I've just presented.
Gosh, so you've got 2 years to go, is it?
Yes, I do.
Sorry, my phone, someone's WhatsApp calling me and I've got no idea how to stop it. So I'll try to turn my phone off. Yeah. Sorry, but oh man.
Very popular.
I didn't even know my phone could take WhatsApp video calls. So what sort of, is it all psychosocial interventions that you're looking at? Have you got any sort of working definition or?
It is so from basically service communication and what is available at the moment, psychosocial interventions within different services within the UK vary quite a lot, the way that they're delivered, setting. So therefore I'm being broad so that I can have in the study 5 sites which broadly target and have psychosocial intervention components within them.
But like define psychosocial, because I get the feeling that sometimes it can be quite loose, your psychosocial intervention.
Yes, so that was a bit difficult to narrow it and find services who meet these criteria, actually. But we do have 5 services now that have defined psychosocial interventions.
Well, that would be fascinating. So is the plan to get ethics of approval first, and then when can you come back and tell us your results, is what I'm wondering.
Hopefully within a year. Once I've received ethics and the data is collected and analyzed, that will be within a year. But I hope that the protocol will be able to be published prior to that. It's a practice within Realist evaluations to publish the protocol because it's very helpful for other evaluations to follow similar.
Great. Well, there's lots of comments in the chat that it all sounds very interesting and useful. So we look forward to hearing more about it. Alex has got his hands up.
Yeah, thanks, Iveta. Really interesting. Just one question. Perhaps it's the same question Jenny was asking, but I was thinking about kind of peer support and peer involvement interventions. Is that included in your psychosocial intervention, or is that not? And again, the role of the peer involvement role in your, have you got some people with some lived experience, I don't know, helping you shape it? Because I think it's there's some quite particular experiences around drug use on the street, for example, and young people, etc.
So I have input from 2 advisory groups for the design and the information sheets, interview protocols, and how to design. I've had some input from those, and they will be helping me later on with dissemination for outside of research environments. In terms of peer groups within the interventions themselves and sites, those are also included. So if there is a formal peer support group which is available at service and there's young people accessing that, then that is also included.
Great, thank you.
Okay, thank you. There's no other hands currently up, so I'm going to seize the opportunity to have a 5-minute break. But thank you so much, Iveta. We wish you all the best with it and look forward to hearing more. It's such a, I guess, an unexplored area, isn't it? That people hope that there's something that they're doing that's useful, but it would be really good to have some evidence showing that it is. So hopefully it will really make a difference to how services are planned, change the shape of things.
That's what I'm hoping as well. Thanks a lot.
Really good to hear about it. So I think I would like to have a little break, comfort break. I'm sure other people would too, but please come back because we've got Emma Adams talking about an intervention for substance misuse in Northeast England during COVID after the break, and we've got lots of things to discuss in any other business. So if we could meet back here at 11:05, and we'll carry on with that. Thank you to both the speakers so far, and thank you all for coming. Bye for now. Jenny. I think everyone's back, and it's 6 minutes past, and everyone's come back, which is wonderful. Hello again, everybody. So we've got another speaker, and then we've got any other business. So this is something close to my heart: access to community-based mental health, drugs and alcohol support in Northeast England for people experiencing homelessness during the COVID-19 pandemic, learning from a co-produced qualitative study. Feels like a long time ago, the COVID pandemic. Hopefully it stays in the past and we can use it as a historical thing rather than something that's going to become current again in the next couple of months. Let's keep our fingers crossed. So Emma, I'll hand over to you. Emma Adams.
Thank you, Jenny. I was going to say, and I have to apologize for the length of that title. It's a mouthful for anyone, let alone someone who isn't me having to say. So I'm hoping everyone can see my slides. Jenny, I can only see your face, so if you could just perfect thumbs up. So I'm really happy to be here today, and cheekily, there's a couple folks on the call who are also part of getting this study to this point. So they might be able to help with some questions and help keep my memory in check as we go along. But I wanted to start today off with a story, sort of rather than maybe some statistics. So in the beginning of January 2020, Andy was living with his dad in council housing. When the initial lockdown started, he was scared, but he knew with his dad by his side, everything was going to be okay. Unfortunately, things took a turn for the worse when Andy's dad suddenly passed away from COVID during the summer. Before he knew it, he was being kicked out of the place he'd been calling home. Andy had become homeless. He hopped from couch to couch, but ended up in a hostel, and it wasn't like anything he could have expected. He found himself having to drink to deal with all of his grief and sort of anxiety and depression. And he didn't know where he could go to get help for his mental health and later his sort of substance use. And I guess the question I ask everyone is, if you were in Andy's shoes, would you know where to go? Would you know how to get access to that support? And I think, unfortunately, that experience is all too common, and a lot of people just don't know where they can go. So Andy's story sort of really, I find, explains why we sort of set out to explore and understand access to community mental health, drinking and drug support within Newcastle and Gateshead during the COVID-19 pandemic from the perspective of people who experienced homelessness and also those who provided that support. And so for today, I'm really going to focus in on the experiences of people who experienced homelessness. And the one thing I would say is sort of the study was only possible through collaboration with amazing community organizations locally and also more national groups as well. So the question is, how did we do this? And I think I've used a lot of exploring, understanding. And so for me, those are always good indicators that I sort of sat down and spoke to people. So I spoke to people who experienced homelessness using sort of the broadest sense of the definition. I know the last person sort of hinted that homelessness can be more than just rough sleeping. It can be sort of a whole variety of different experiences. And so I ended up speaking to 16 men and 10 women. And just to sort of understand what they were able to access or not access during the pandemic. After speaking to them, I worked with 5 people who had lived experience of homelessness, mental health, and or substance use to really make sense of all that data and make sure that when we were exploring it and understanding it, we were really capturing what was there and we weren't sort of jumping to any conclusions that weren't in the data. So today I'm going to talk to you about sort of the 3 main themes we identified in our study. At a very high level. And so I'm going to just walk you through each one quite quickly. So the first one is looking at this idea, which we call sort of inadvertent exclusion, which I realize is a big word and fancy word, but at the core, it's this idea that, you know, obviously service provision had to drastically change during COVID. I think, you know, prior to March 2020, a lot of people wouldn't have dreamed of offering services online or remotely. And so we had to make quite reactive changes to ensure that support didn't stop and to provide something versus nothing. But often those changes led to people just feeling like they couldn't access support. And so within our theme of inadvertent exclusion, we identified 3 main ways in which people sort of felt that they were being left behind by services. So the first one is sort of, I like to say, my North American Dolly Parton obsession coming to light, and it's sort of mental health isn't 9 to 5. And this is probably something that isn't necessarily unique to the pandemic, but I think was just really made all the more apparent when services sort of closed doors and there was less offering of services. And so there's a quote on the screen that hopefully everyone can see. And so it really highlights this idea that, you know, sometimes you're feeling your worst when it's late at night and, you know, it's dark, and that's when you feel your most loneliness after 10 o'clock when no one's around. And so it's highlighting this idea that, you know, there often wasn't services available after hours, and some of the after hours support that might have been available prior to the pandemic was changed and people couldn't access during COVID. The second theme is all around digital exclusion, which I'm sure a lot of people are probably very aware of. And I think it was this idea that pre-COVID, although things weren't perfect, being able to access services in person was always seen a bit better than accessing things online, although people had to balance requirements of having to travel and the cost of traveling to services. And I think something that was really interesting that came up was this idea that, you know, there's this transition to digital support, and in some instances, services provided people with phones or computers to access that support, but that was sort of almost a band-aid solution, because a lot of people didn't know how to use that computer or use that phone to then access services. And a lot of people said, they left me with this computer and I didn't know what to do with it. But also, they might have received a computer, but then because they were in a hostel, the computer was stolen, and then they went back to square one again. The sort of final area in this sort of exclusion is just knowledge and awareness of what support is out there. And I think with that, it's this idea that having the knowledge and understanding of who offers what support and where you can go and when you can go was one of the biggest facilitators or barriers to accessing services. So if someone had that knowledge, they could get access to services. And if they didn't, then, they just couldn't. They were sort of stuck spinning around wondering what to do. And people had sort of suggested that when we share information about support, it's never going to be a one-size-fits-all approach. And they said during the pandemic, a lot of that knowledge sharing was done electronically or through text messages, which just didn't work for a lot of people. And I think something I found really interesting is the variety of ways people hear about support. And one person actually shared an experience where, they passed the football stadium and they saw a sign at the football stadium, and that's how they knew what number to call when they needed support at 2 a.m. And, I personally wouldn't think of a football stadium as my go-to place for knowledge. And so just that idea of having information shared in all different spaces, whether that be libraries, football stadiums, washroom toilets, bulletin boards, all those things, and just making sure that that information was shared in such a way people could understand. I think there's this quote on this slide that really sort of reiterates this idea that sort of once you're in that circle of homelessness, it can be really hard to access anything. You don't know who to go to or who to speak to, who to contact. It's just extremely difficult to know what to do. But people spoke about how sometimes they heard about a support before they were in that situation, and then they had the knowledge to go and say, okay, well, I heard about this before, I'm going to reach out, or I think I can access this service now. The sort of second set of themes we found were all related to barriers to recovery. And I think what that is, it's just highlighting the fact that a lot of people had very negative experiences accessing care or faced a lot of barriers and challenges when they access support, and that those negative experiences really shape people's attitude towards accessing support in the future. And so we consider it a barrier to someone's recovery because it impacts them longer term than just that one interaction, and it needs to be something we recognize. So the first area within that was this lack of space for recovery, and I think this quote really captures it. It captures this idea that often the place where service is provided when it's in person isn't the best place for people, in that it takes them back in their recovery to maybe some of their negative emotions and negative feelings. And we need to be really aware of how the space in which we provide services can really impact people for the better or worse. And something that really came up was this idea that, they might need different spaces depending on their level of recovery. So one person said, maybe that initial sort of slightly more walk-in based service is okay at the beginning, but as I move further along in my journey, I don't want to have to go back. I want to go to a new place, a place that's clean and a place that's sort of supportive and welcoming. The second area was around sort of disjointed care and repetition of recovery stories, which I'm sure most people on this call will understand. And I don't necessarily need to go into too much detail, but it's this idea of having to explain yourself over and over again and just feeling like it's never ending and people aren't communicating. And I think perhaps this was even more brought to the forefront in COVID because there was all those constraints. There was a lot of staff sickness, there was staff turnover, and it was harder to recruit people into roles. And one of the things that people spoke about was just this need for organizations across the health and care service. So things like housing officers speaking to NHS nurses, or a drug and alcohol worker working with their peer support worker, and working together to help someone. And I think that's where, a big term currently is sort of integrated care. And I think that's really what is highlighted here. The third one is on this idea of just not being ready for recovery, which is something people talked about a lot. And I think it's really interesting in that, people could explain that they weren't ready to get help for their mental health or substance use at that moment because they had other priorities, whether that was housing or getting a job, or for some people, you know, getting their child back who maybe wasn't with them anymore. But although they couldn't always say, you know, this is what I would need to be ready to get help, the one thing everyone did say is being forced into help wasn't the solution either. And so they felt as though people should be given adequate space and time to get help, and it was okay to be there along that journey, but we shouldn't be pressuring people to do certain things because that just leads to them wanting to disengage and not being receptive to accessing services in the future. Final area is around this prioritization when sort of things are trying and when we just don't have a lot of support and services. And I think this is something that, you know, although it was really obvious during COVID, is probably something that will continue to be an issue in the system, is just recognizing how we prioritize things. And so something that came up is people feeling like they were constantly hitting a brick wall when they were trying to access support. And you can see this here where someone sort of shared an experience calling the crisis mental health team 9 times before they actually came out. And they sort of said rightfully that the crisis team is pretty much the wrong name for them. And I think it's this idea that in the pandemic, services felt fewer and farther in between. I think a lot of people a lot of services redistributed what they were doing around sort of maybe infection control or vaccine outreach. And as a result, they just felt like there just wasn't the services there, and that maybe there should have been a better way to recognize that they couldn't just eliminate everything and make sure that adequate support was there for people going through sort of challenges with their mental health and substance use. So I recognize that was all fairly negative to a certain extent, and quite focused on what we could be doing differently and maybe where things went wrong. And so our final theme sort of is taking a more positive spin on it, and it's looking at this idea that, you know, we probably don't always offer support in the best way. And I think we've heard things about, you know, psychologically informed environments. We hear things about person-centered care, and it's this idea of sort of recognizing that we need to have a system that's reflective to the needs of people and that actually supports people in doing what they're doing versus making people feel worse. So the first sort of sub-theme within that was looking at the disconnect between service provision and need. And I think with that one, it's probably quite common, is the analogy of someone who has, you know, mental health challenges and maybe needs some psychotherapy or needs some support around their mental health, but they're currently drinking, and so the mental health worker can't help them because drinking means they can't access that service. And so something that came up, which I'm sure a lot of people on the call will agree, is just that we can leverage lived experience and work with people who have gone through this journey to really understand how we design services better to support needs and find ways in which we can work together to ensure people aren't hitting these brick walls, and to make sure that when people need a support, they're able to get it and they're getting the support at the right time for them. The second area was all around choice and an active voice. And I think something that came up was during COVID, you know, even more so than normal, people felt like they lost a lot of control on their circumstances and they had really limited choices. And so I think someone said something to me, which was this idea of, if I came into a room and someone said, Emma, you can have a black coffee and only a black coffee, nothing else. You know, I might be happy with that because I drink black coffees, but the next person might not. And so it's this idea of, you know, reframing some of the things. And we can't always give people a choice or a say in everything, but something as small as sort of saying, would you like a coffee or a tea? Or would you rather we meet on the phone or in person? And just giving people that autonomy and that ability to have a say in what they would like was really important. And they suggested it's something we needed to do moving forward. So that was a lot of information. And I guess the big question is, why does this matter? And why should we care? And what can we be doing? So on the screen, you'll be able to see 2 visuals, which we sort of co-developed based on the findings from the research. And on what I think is your left-hand side, because it's my left-hand side, is the one with the cloud in the upper right-hand corner. And that's sort of all the barriers and experiences that are quite negative when accessing support. And by contrast, the right side, the parallel image of the mountain, presents some of the ways in which we can rectify some of those issues and some of the strategies we can put in place just to address those things and make sure people are better supported along their journey. And I think some of the big takeaways we had was, you know, this idea of if we're going to offer digital or remote services, we need to do that with people with lived experience to make sure that they're appropriate and inclusive, and all the training that's required is being provided so people feel empowered versus disempowered. There was also this idea about making information about services accessible, and that's something as simple as just making things clear and using English language it's easy for anyone to understand. I'm guilty of reading forms at times and thinking, God, I don't know what on earth's in this form. And the best way we can do that is by talking to people who we're looking to work with and looking to serve and saying, do you understand this? How can we make this better? And then I think the final way we can do that is by creating safe spaces for people to access services. And so that's safety in terms of, you know, removing some of the power imbalance and making people feel as though they have a role in their recovery, but also making sure that the environment they're coming to isn't encouraging them to use drugs. It's not as though they're having to cross through people using drugs and being told, oh, here, have this, have that on their way in. We need to be really aware of how the service is provided and the space in which we offer services. That's sort of a snapshot on it, and the paper's out now, and I'm happy to share that with people. And if you have any questions or thoughts, feel free to put it in the chat. I just want to say thank you to sort of the people who funded the study, but also to the folks who sort of came along the journey with me, sort of the people that lived experience, a couple of whom are here today, who without them, we probably wouldn't have found the results we did and wouldn't have thought through them, I think, in the way we did.
Thank you, Emma. That was really interesting. Really interesting, and lots of it sounded very familiar, I think, probably to lots of us in the audience, the themes of digital exclusion and of I think prioritization of needs is a kind of polite way of putting it. Sort of the needing help but not being able to get any. I was wondering, in the Northeast, what was the sort of COVID homeless provision? In London, we had all these hotels that opened. Did you have?
So it varied depending on the area, and so certain local authorities had hotels that were able to provide services. There were other local authorities that already offered more private-based accommodation where it was already single-unit occupancies, but those local authorities maybe didn't necessarily have the homeless numbers that we saw during COVID. I guess a selfish plug is we're currently trying to understand what actually happened during COVID and how the support that was accessed from a housing perspective impacted on people's health, including mental health and physical health. And I think part of that is just the fact nobody did the same thing, or very few areas did the same thing. And I think that made it really hard and really frustrating for people because they might be able to access something in Newcastle, but that same service wasn't being offered in Gateshead.
Mm-hmm. And so Suzanne's just commented in the chat, I'll speak for you, Suzanne, but saying that it's important that COVID ways of working aren't accepted as the new normal, which I think is really true. But the digital exclusion is particularly important, but also the, as you say, Suzanne, we keep banging the drum about multi-agency working and co-location of services. So mental health and substance misuse being so separate is something that I feel like I've been talking about for 15 years. I wonder if where you're planning to take your paper, because having done the research, how can we use it to shape policy, do you think? I don't know how receptive government are to anything, but are there any plans?
Yeah, so the paper's been shared with the Department of Health and Social Care, and I sort of have a project funded through one of their policy research units right now. So I'm working with some of their inclusion and homeless health teams around that project, and they've seen this paper. I think, you know, Suzanne pointed a really sort of pertinent thing, which is like, we can't just say, oh, things worked okay during COVID and that's what we're going to do now. And I think part of it is just having those honest conversations that it wasn't that great, and that, you know, some things might have been better, but overall it wasn't. And so we have a paper right now that we're writing up, and I'm just dealing with comments from co-authors, which is looking specifically at the impact COVID had on people's mental health and substance use. And I think that one will be a nice complement to say, okay, these were the issues around access, but what was this actually impacting on for people? And that paper was a specific ask from Department of Health and Social Care colleagues. And so they will be having it given to them every way till Sunday, whether they like it or not. And they also, unfortunately, have to listen to this exact presentation on Friday. So
okay, well, that's really good to hear. I'm glad that it's getting heard by someone. If you need any more anecdotal evidence, I'm sure that all of us here would be very happy to supply anything that you need.
Oh,
if you find a receptive ear in the Department of Health and Social Care, we're all here to speak to them.
Yeah, and I think the other thing that worked out quite well is those visuals, at least in the Northeast, have been sort of posted up in different service providers across the area. And I think sometimes just having that visual element, like, I mean, I'm guilty. I had to reread my paper this morning because I was like, this feels like such a distant memory. And like, I am that person that hates reading papers. But I had to read it this morning, but the visual sits beside my desk each day, and the visual is that constant reminder. And I think a lot of providers have said just seeing that visual element is a reminder to them, but also for service users that come in, they can see sort of, hey, I don't understand that either. It's not just me. And I think there's something to be said about how we communicate things. And I think, you know, I take no credit for that idea. I think that was all Jeff and Tony.
Who drew the visual? Because it's fantastic. It's a very talented person who managed to make a visual from it.
It was a lady from More Than Minutes, and she did all of the Health Now visuals for Groundswell's Manchester comics. And so I was able to get the referral, and she was amazing. And I would strongly recommend to anyone that needed something like that done to reach out to them and work with them, because they were great.
Thank you. Well, so yeah, it's a very strong and immediate way of putting the information, isn't it? Suzanne, I see your hand's now up. Thank you for joining.
Yeah, I just had a specific question really in relation to that comment that I put in the chat, which is whether there's anything in your the output from your research specifically about co-location of services. It feels like that's a little battle that's coming up really. You know, services have been so separated during COVID, and there's a danger that we're going to be continuing that on the grounds that, oh, we can all email each other and we can all phone each other and instant access to everybody, but it's not. It's not the same as being able to wander down the corridor and bump into someone as you're coming into work or making a coffee or.
Yeah, so unfortunately it didn't come through in the sort of folks who experienced homelessness. The provider interviews, it came through a little bit, but I think what came through more in that was just like the frustration around not knowing what each week was going to look like. And I think that then overshadowed maybe some of the issues around, you know, the practicalities of that. I think we're currently doing a study, and I think the co-location element's really going to come to the forefront for that study, because it's looking at how, you know, in different areas across the UK, when they did the Everyone In initiative, certain places had like psychologists embedded, some people had drug workers embedded in the physical service. And so I imagine that's where a lot of the co-location stuff's going to come out. But I was a bit disappointed when I didn't see it in the data. But I think it was probably because there were so many other things that.
It'd be great to have copies of what you've got written already.
Yeah, definitely.
Yeah, are there any other questions? Alex, your hand's up.
Thanks, Emma. Fascinating. It was not really a question, but just in terms of your conversation with the Department of Health and others, just, yeah, do keep us in the loop, because we're often talking to those people and how we can collectively influence. Sometimes if they keep hearing the same thing from different people, that's quite a good method to get them to move a little bit. Think about NHS England as well. Are you into them at all?
No, so not, at least not for the current. We've got, I think it's, and I get all the abbreviations wrong. It's OHID, Office for Health Improvement Disparities.
Right, yeah.
EHSC, and then there's one that's a heck of a lot of letters, which has like housing, local government, and something else in there. And it begins with an M, and the letters all blur together in there. Is who we're working with mainly for our current stuff.
If you could drop us an email just saying who you're in touch with, then we could just keep an eye on that and maybe come and support you where we can.
Oh, that'd be amazing. Thank you.
Okay, thank you, Emma, and all our speakers. That's been really, really interesting talks today. We've got a bit of any other business, so we'll move on. I think Dan and Alan are here from Dual Diagnosis Anonymous to tell us a bit about that. Are you there, Dan?
Yeah, hello Jenny. Yes.
Hello, Dan. I can hear your voice. Oh, there you are.
You see, yeah, nice to see you. Yeah, my colleague Alan is here as well, and yeah, we just wanted to sort of jump in if that's all right, and just let you know a little bit about, let you guys know who we are really. So Alan and I started Dual Diagnosis Anonymous in 2016, and it already exists in America, and is really big on the west coast of America. It was started by a guy called Corbett Monica in America, who was dually diagnosed himself. He was a Vietnam War veteran. He'd come out of the war with some mental health issues, and he picked up a heroin habit, and basically sort of got found recovery himself, got his mental health got stable. He recovered from his drug issues, and he became like a counsellor in the prison system in America, and he was taking some dually diagnosed people. This is a very brief history, by the way. He took some he took a couple of dually diagnosed people to an AA meeting in the late 90s, and was politely asked at the end of the meeting, not sort of, thanks for bringing those guys along, but please don't bring them back because they're too unwell. So so Corbett basically, as a sort of response to this, got permission from AA to use the 12 steps, and then actually sort of wrote an additional 5 steps, which specifically addressed the mental health aspect of a dual diagnosis. So he's created a sort of specifically tailored 12-step program for people with co-occurring mental health and addiction, substance misuse issues. So basically, Corbett got a small bit of funding in the late 90s to start some more meetings, and managed to get 50 going in like 2 years. And now there's well over 100 meetings in the state of Oregon, and they're both in the community and in prisons and on mental health wards and everywhere really. So cut long story short, I met Corbett in 2014, asked him permission to bring DDA over to Dual Diagnosis Anonymous over to the UK, and basically Alan, I don't know if you're there. Yeah. I'll hand over to you in a sec, Alan, if that's all right. But so I came back from America, and I wanted to get DDA going, and I thought Alan and I are old pals, and I thought of no one better to help me sort of set up DDA. So I don't know if you want to go from there, Alan.
Yeah. Okay, Dan. Thank you.
Cheers.
Yeah. Thanks, Alan, DDA. Yeah, well, when Dan came over, right, it was a no-brainer, right? He kind of asked me, well, he informed me first about his experience in America, that he'd come across DDA, this organization based on the 12 steps, but with an additional 5 steps that kind of focused on the mental health side of a dual diagnosis. And when he explained it to me, right, it was absolutely a no-brainer. Right, I wanted to get involved in trying to get this off the ground, right? Because I just knew its worth, right, and I just knew its need, right? There was so many of us, right? I mean, just to give you a little bit of background on myself, right? I lived in active addiction and active alcoholism for 32 years, right? And I made my recovery in 2009. Right, I moved from 22 years of addiction in drugs. Right, I never drank. when I took drugs, right? But when I started to put down the drugs, I picked up the drink, right? And I moved seamlessly from addiction to alcoholism, right? And I lived for a further 10 years in alcoholism. So in total, it was 32 years. And I made my recovery via AA, right? And which was great. It was a spiritual kind of program, right? Which was what I needed. I suffered from a spiritual malady, right? And it was perfect for me. But there was no emphasis within the fellowship on mental health. So it never came to light to myself that what had actually drove all my addiction issues was my mental health, right? Because I couldn't share, right? I couldn't talk openly in fellowship. I mean, forget the professional framework where you're asked to separate these two co-occurring conditions, right? You're asked to talk about your addiction over here and your mental health over here, right? And the two things are happening together. It's a totally unrealistic ask, sorry. And that was what was asked of me inside the professional framework, to separate these two co-occurring conditions. And even in the fellowships, right, and I attended all of the fellowships. I attended AA, NA, CA, because I had a problem with just about every substance under the sun, right? You know, and so I belonged in all of those fellowships, and I attended them all, but they didn't focus on mental health at all, right? And you stigmatized yourself from talking about mental health, your issues with mental health and your issues with medication, side effects of medication. You kind of like, oh, it's not for me to talk about that stuff here. So even in fellowship, you're trying to separate the two co-occurring conditions, right? And then when Dan came over to me and spoke about DDA, this program based on the 12 steps, because if something's not broke, don't fix it, right? You know, it works for many people. The 12 steps work. That's why it's applicable in gambling, in alcohol, in drugs, in sex addiction, in all kinds of, it addresses addiction, but it does not focus on the mental health, right? You know, so Corbett, who Dan has told you about, came up with this idea to formulate a program specifically for people living with complex needs and a dual diagnosis. And he came up with this idea of using the 12 steps to address the addiction side of things and using the additional 5 steps to incorporate mental health. So that's what he did. He went away, he wrote the most, I mean, his kind of legacy to us guys, besides the formation of DDA, was a journey through the 12+5. He wrote this book and he published it the year before his death. Sadly, he died 3-4 years ago, right? And but before he did pass away, he wrote this book, which was a journey through the 12+5, which starts with an opening meditation to each step, an introduction to each step, and then exercises on how this step appertains to you, right? How does it relate in your life, right? So, you know, he produced this book, which was fantastic, and is like the crux of DDA. So Dan came over, told me of his experience in America, of his coming across this kind of fellowship that was duly diagnosed, a duly diagnosed anonymous, right? That concentrated on not only the addiction side of the dual diagnosis, but also on the mental health side of the dual diagnosis. And I was sold, right? And I became involved in trying to get this off the ground. And we worked really well for the first 2 years or so. We managed to go to the commissioners, right? And the commissioners were fantastic. And this was in real times of austerity, right? When the commissioners was having their purse strings kind of restricted each year, they were becoming less and less, but they believed in us so much, right? That there's a real need for a fellowship such as yourselves, duly diagnosed anonymous, right? And they invested in us. They gave us a few pounds to set up a website, to create a few meetings, and everything was going really well. We was just reaching the stage where we was looking to how can we expand and become national, because we felt almost as if we was like gifted to hold the golden egg, right? Right? Something that's really going to this peer support model. And importantly, it's peer support. It's a peer support model, right? That really, kind of supports these people living with these complex needs, right? And we kind of knew, the value of this, right? And we wanted to get it off the ground, right? And the commissioners was really helpful. They stamped up this money, which allowed us to set up a website, to kind of get a few meetings going, and everything was going really well. And then the pandemic hit, right? And that really affected us, right? When the pandemic hit, obviously all the face-to-face meetings, we'd got 6 going, right? There was one on every day of the week, except one day, right? So we'd managed to get 6 meetings going in the West London area, right? And we started to grow, and we was just looking to develop nationally when the pandemic hit, and that restricted us. We had to go to Zoom. Zoom was a double-edged sword, right? As has been spoken about, right? It enabled us to open up to people who wasn't from West London, right? Formerly, DDA was only kind of obtainable and you could only kind of access it if you lived in the West London area. But because of the pandemic situation, we went onto Zoom and everybody was accessible to us. We now have people from America, people from Scotland, from Manchester, from Liverpool, from here, there, and everywhere, right? They can access DDA because we've gone on to Zoom. So that really opened things up. And we're kind of building on, we're looking now, because the pandemic situation is over, to kind of come back to face-to-face meetings. I mean, I facilitate the one and only face-to-face meeting that we've resumed is in West London. And, and something that has been said here, right, in the meeting was, you cannot replace the power of proximity, right? So much of our body language, right, is incommunicable, right, over Zoom, right? So much you need to, 4/5 of what we speak and say is non-communicative, right? It's body language, right? And you need to be in the room to kind of be able to pick up on that, right? And that's lost in Zoom. So there is a downside to going to Zoom, right? But there is a plus as well, in the sense that it's opened us up to everyone. And we're at the stage now where we're trying to bring this resource to everybody. It's an amazing resource, right? The freedom, the liberation, right, that people have in DDA, the ability to be able to talk openly, right, not only about your addiction issues, but also about your struggles with medication, your struggles with the side effects of medication, and to get positive feedback. And we only allow positive feedback, right? Not deconstructive, right? Not, you can't challenge people's opinions but you can give positive feedback. And the kind of availability to be able to receive positive feedback from your peers, right, really gives you this sense of belonging, right? And people living and managing a dual diagnosis really feel this sense of belonging in DDA, right? This liberation, this, like, the shackles are off, right? I can talk, right? I can talk openly. I can say, well, I'm on quetiapine and it's causing such weight gain that's really bothered, right? And they can speak openly, right, and be kind of fed back to by people who say, oh, I had that experience, right, and you know what I found, right, helpful was to do this and to do, right, so they can receive positive feedback, and this is so liberating, right, so it's just a case of now, how do we grow this? Because it really does feel like, you know, we're the custodians of the golden egg, right? You know, that we need to get out there, right? Because there is such a need for this fellowship, right? For a fellowship that incorporates both addiction and mental health, right? Yes, there's a need for AA, there's a need for CA, there's a need for all the GA, all the single purpose fellowships. But the difference is, right, in single purpose fellowships, the primary kind of objective in a single purpose fellowship is to carry the message to the still suffering alcoholic and addict, right? And any kind of diversion from that, right, is seen as a diversion, right? And you're asked to rein it in, right? You know, oh, please, our primary objective is to carry the message to the still suffering alcoholic addict. Any talk of mental health or problems with, you know, mental health medication and side effects of mental health, right, is really not welcome. So a person stigmatizes themselves. They try not to talk openly in that arena, whereas in the arena of DDA, they can, right? And they do. And they feel such liberation from being able to do that. And then being able to get positive feedback from your peers who might not have gone through exactly the same, but might have gone through something similar and might have had some positive feedback to offer, right? You know, so this is what DDA is. And we just want to get it out there, right? It's based in, okay, it's based in London. We are on Zoom, which does enable, I mean, we have a very, very close working relationship with our founders in America, right? So a lot of the people who attend our Zoom meetings come from America. A lot of our people who come from the UK join the American meetings. So we have quite a crossover, right, of people joining American meetings and Americans joining the UK meetings. And, you know, we have the beginning of something amazing, but we just need to get it out there.
And then
we run out of time.
Yeah. I'm subtly giving you that message. So I have to say I'm an enormous fan of Dual Diagnosis Anonymous because I met Dan, about 5 years ago when he was brilliantly managing one of the direct hostels in South London that we work in. And I was very, very lucky because I got to go to a Dual Diagnosis Anonymous meeting in Hammersmith, and it was all the things that they're saying. It was really fantastic and such a exciting place that felt so safe and innovative. So I was very lucky to go there. And what's the current state of play? Is it Zoom meetings only, or are there any?
So at the minute there's about 5 or 6 Zoom meetings a week. They're all on the website, which I put on the chat. So if you have got clients or people you work with, or if any of you guys as professionals want to attend, anyone's welcome. And that's the other thing we promote, that like holistic approach to recovery in general, and professionals are just as important as peers, sort of thing. So they're all on the Zoom. There's like I said, about six Zoom meetings, 1 in-person meeting in West London at the moment, all on the website. I've also put up 2 academic evaluations of dual diagnosis, which were done by the University of West London and published, which show you the kind of the positive benefits of attending meetings, the reduction in isolation and compliance with medication, lots of evidence that it showed. And there was also another study on the effectiveness of us during COVID. So worth a read if you've got 15 minutes to have a read through them, really useful. But also the other thing that we wanted to sort of really plug today was, because it is just Alan and me doing it in our spare time, really, we we've been trying to think of ways how can we grow this, and basically we've kind of come to the conclusion that we want to just, if you're out there or you know people out there who would be interested in starting a meeting, we have put a meeting pact together for like a meeting pact together. So we're going to put it on the website. I've sent it to Alex. I'm not sure if you've had a chance to distribute it yet, but hopefully you guys will get that information. And it's basically telling you how to start your own meeting if that's something you'd like to do, because that's what we've kind of realised is going to be the best way to grow it. And we can kind of, if you would like to do that yourself, or you know someone or an organisation who'd like to do that, we can support them with it. So
Great.
That's the big plug for today, is start your own meetings, in person or online. Yeah, please.
Gosh, okay, well I hope people do, and I urge everybody to read the website, because as I say, it's really fantastic. I hope that it becomes available everywhere, and I've certainly recommended people go to Zoom, but Zoom meetings, but it's sometimes difficult because of the digital exclusion, so
yeah,
that's another thing to think about. But thank you, Alan, for talking about it so passionately. It's a really great resource. John's hand is up. John.
Yeah, just to say again, thank you very much. Very powerful. And I look forward to recommending to my patients what you're doing. And I'll be looking at possibly setting something up in Westminster. So I might well be contacting you.
That would be great.
Feel free, John. Feel free.
Great, thank you.
So, we've got 5 minutes left, which isn't very much time for any other business. But if anyone has anything,
sorry about that.
No, it's really great to hear about it, Dan. If anyone has got anything they'd like to very quickly mention, please raise your hand. I want to plug a conference that I hope people have heard about on the 17th of November at the College of Psychiatrists, which is called No Health. What is it called? No Health Without Housing, and it's about homelessness and supported housing. And I'm going to put the link in the chat so that people can book, and it's face to face, so hopefully we can meet. Oh, I had it all ready to copy and paste, and it's not pasting, so I will put it on the chat in a minute. Meanwhile, Sophie, did you want to, your hand is up?
Yes, I just wanted to say again to everybody, thank you for everybody's contributions to the mental health consultation last time we met, and that I put that in, haven't heard anything back from anyone, but Alex and I have talked about arranging a meeting with Tim Kendall to have a conversation with him about the paper that we put together, and so I'm going to give Alex a little nudge to kind of follow that up again, because we did talk about that. But thank you everybody. We tried to incorporate everything and then put it into the silly boxes that they had on the consultation form, but we do have a paper. If anyone would like that, to have a look at that, I can send it around again. So thank you.
Thank you, Sophie, and thanks for coordinating that. It was a really good discussion we had, and I think it was captured in the response. Alex?
Thanks, Jenny. Yes, just a couple of things from me. Yeah, so thanks for the prompt, Sophie. Just to confirm, yeah, we'll try and get into see Tim Kendall, who is the National Clinical Director for Mental Health at NHS England, to raise some of the issues we raised in that paper. But we could, some other things come up today, we might try and raise with him too. Also, just with Dan and Alan, just say we will send the links around to the main faculty mailing list as well, and be really interested to see what you get from that, and to feedback to us as to whether you get connections from that. The other conference I was going to just pop in the chat is the faculty's next conference next spring, next March, just to share with colleagues that we're also back in the room. So 2 days at a nice venue in central London. There's some colleagues on the line who are part of the team reviewing the papers. We've had more submissions this year than ever, so we've got a rich set of stuff to read through and try and create a great program for people. We've already got NHS England's medical director committed to come, and also the chief exec of Crisis is committed to come and do an opening speech. But so we've working through quite a lot of other ideas. One of the themes is around integration because of the ICSs, and what does integration mean? And I think today that idea that integration might mean that the dual diagnosis and co-location of services dealing with mental health and substance abuse and misuse and physical health, perhaps that could be integration, couldn't it? So yeah, just to plug that event coming up. There's some information on the website. I think there's still an early bird rate, so if you're booking tickets, it's worth booking early.
Thank you.
That was it from me.
And it's always a great conference, that one. I love it. So hopefully we'll see you in November and in March as well. John, I think your hand is a legacy hand, unless you have more words of wisdom for us.
No, sorry. Sorry about that.
Okay, so I will wrap up with slight apologies for it being feeling a bit packed this morning, but it's been great. It's been great to have such interesting presentations and to hear about Dual Diagnosis Anonymous too. I think the next meeting will be in January, and we've already got, I think we're going to hear about the RAMP evaluation. Is that right, Sophie?
Yes.
Already
yes.
on the
London one, because I didn't have any contacts for the national RAMP evaluation, but we can maybe try and tie them together.
Okay, well, if anyone has any contacts for the national RAMP evaluation, please let us know. Otherwise, it would be very interesting to hear about the London one.
Just someone explain the RAMP acronym.
Oh, well, that would mean that someone knows what it stands for. Is Ricky still here? She will know. Do you know?
Hiya. Yeah,
oh,
it's the Rough Sleeping Adult Mental Health Project, and my understanding is it was a London-wide only. I don't think there was RAMP teams back in the day nationally, but I might be wrong. So I think it's just the London one.
Okay, so that's all we can evaluate, because it's all that there is. So
yeah,
what
but
does
it's
it
being
stand
implemented.
for?
So it's the Rough Sleeping Adult Mental Health Project, and it's part of the London Mayor's
Okay.
agenda for improving homelessness for London.
Okay, thank you, Ricky. Well, we'll look forward to hearing about that. I'm sure it'll be a good evaluation. I think that's it. If anyone has other suggestions for the next, or wants to talk at the next meeting, please let me or Sophie or Alex or Jonathan know. Tell somebody, and it will be nice to see you all. Hopefully in November before that, and then online again in January. Okay, thanks everybody for coming.
Bye.
Bye.
Cheers. Bye.
Thank you.
Thank you.
Thanks, Tony.
Bye, everybody.